Hello, this is Surviving Healthcare Podcast, and I have a dear friend of mine who I've known since, how old were we, Jeff?
Oh
Junior high
gosh,
school?
junior high.
Junior high school, and we lived across the street from each other, and we influenced each other and ended up in medical school together at Case Western. And later on, we flew hang. Actually, it was in high school. We flew hang gliders together and did some rock climbing and had all kinds of adventures. And in medical school, before the weightlifting craze started, we started seriously lifting weights in our living room, and we it was an awful lot of fun with one other student plus. And your bro, I don't think was around that much. He was in my other class. I dropped out for 2 years and was fortunate enough to get picked up again, and ended up in the second class. So Jeff's a couple years younger. Jeff was a better student than I was. And
Uh,
he, now, were you that in the AOA?
no, I missed
No,
it by 1 point.
your wife was, though. Your wife,
Yeah,
your
yeah,
wife was, which
much
is
smarter than we were about.
top 10%. Well, more better student anyway.
Yeah.
And so Jeff is an orthopedic surgeon. And today my topic is orthopedic joint replacements, which he's done an awful lot of. He's retired in the last 6 months. Is that correct?
Actually, it's been about a year and a half now.
A year and a half.
Time
Time
flies.
freaking flies. Yeah. Well, I keep telling people I've been retired 2 years, but it may be like 3.5. So well, the first thing we ought to do is compare. As old dogs, we have to compare our injuries. Now, I've had I've pulled off my quadricep off my kneecap, and I ruined a biceps tendon, so I've got a biceps that doesn't look so pretty anymore. Both climbing, and then I've had two shoulder replacements. Now I think and then I chipped a tooth when I was climbing. I was hanging on for dear life, and you always feel like you're going to die if you fall. And so I think I hooked a tooth over a little ledge and fell off and broke my tooth off. Was that stupid or what? But Jeff, I think, is at one hip replacement, and that's all the problems he's ever had.
Oh well, Bob, I would say that you're ahead of me a little bit. I guess we're always our own worst enemy, but I most of my problems were probably more genetic, and I didn't lead quite as an adventurous life as you did. But I'd like to claim that fame, but I don't have that ability. But anyway, yeah, we're getting older. We do share some common ailments now.
Okay. So Jeff has had quite a storied career. He got a top orthopedic residency at Washington University in St. Louis. And this is really top, I think, is the top couple in the country. And I think you did a fellowship in joint replacement as well, didn't you?
I did, yeah.
And that was primarily hips, or that was all kinds of joint replacements?
Well, the way it worked, and thank you for the kind introduction, Bob. um, the way it works in orthopedics, so my path led me that direction, yours in a different direction. But orthopedics is, comprises of several subspecialties, and I chose joint replacement, which is called adult reconstructive. Anyway, so that's all about the technology and the form of treatment that takes us old guys and puts us back on the field. Um, just as an aside, and you and I both know the old joke. The most gifted students actually went into the internal medicine related fields, and then everybody that was left, like yourself, everybody that was left, like me, ended up in orthopedics, right? It was kind of the jock or the blue collar, subspecialty preference by default. But anyway, yeah, things have changed a little bit. It's a much more sought after training program now, and especially within the field. And I think a lot of that has to do with the economics of medicine. But nevertheless, I ended up doing that, and I thought I was pretty well suited for it because I kind of grew up with tools in my hand, using my hands a lot, and home repair and auto mechanics and that kind of thing. And it just seemed to have a lot of appeal. The old joke, Bob, you remember when we were in school, in the hospitals, you could always tell the orthopedist from the internal medicine people, because when running for an elevator, the internal medicine guy would reach in with his hand. Well, orthopedists, we'd use our head, got to protect the But we had the last say because we could always remind them that that in the end we were all internists, but the difference between surgeons and internists was that we could operate. So
Yeah, it's a lot more competitive to get into ortho now than it is, and it's a very select group. And I don't
neither of
doubt.
us would make it now.
Who knows? So um, so we're going to go over these surgeries, the complications and the problems and the various adventures Jeff's had during his career. And the interest, or my entree into this, was that I had 2 shoulder replacements within the last 6 months, and I'm about 8 weeks out of my second one, and I've been sick and haven't been doing much rehab, so they're a little stiff right now. But I've got every confidence I'm going to have a fantastic result. And Jeff, how many of these did you do during your career, shoulders?
Well, I did shoulders less frequently, but primarily because, they just weren't done as commonly. That's not as common an ailment. The incidence of shoulder disease in the patients who would be appropriate for surgery is just not that great. By far, the most common ailment that is treatable with joint replacement it involves the knee, then the hip, then the shoulder, probably then elbow, wrist, ankle, that kind of thing. So there's kind of a hierarchy and frequency that that you'll see joint replacement being done nowadays.
I just go ahead. I just
Well,
remembered a story that I have to interject before we launch into this thing, and that is Jeff and his brother were very mechanically inclined, and they had training. Their father ran an entrepreneurial washing machine company that had tendrils in all of the Midwest, as far as I could tell. And he believed in working the kids. So the kids had to go over and work at the various projects. And I mean, Jeff's brother was my exact age contemporary, and he went to dental school. He was very well suited for that, went to the same school we went to. And when we were hang gliding, he got a kit to put together this hang glider. It wasn't like today. These things were like very beginning stage hang gliders. It was called a Brock Regalo. And he got pipe fitting, and he put this thing together with rivets and screws and bought the sail and stretched it over the thing. And we just jumped off the top of the cliff, and it worked. It worked. And Jeff's father, who I was very fond of and mentored me in a lot of ways, took us to Florida multiple times. He actually almost flew the hang glider himself, but we have photographs of him standing at the top of the cliff and flapping his wings and declining to launch. Declining to launch. But anyway, wisely, he said, "We don't know what's going to happen to you kids if I break my neck." That's what he was quoted as saying. Okay, so sorry to take you off the path. You can look at my both-sided shoulder replacements. There's some steel in there. I'll include the x-rays in the show notes, and also include Jeff's cell phone number, so you can call him for questions. No, I'm kidding about that. Jeff's had plenty of questions.
I have a little button that I can turn off.
Okay. Okay. So I didn't realize that more knees were done than hips.
Yeah. Knees are by far the most common joint that's replaced.
So you have as much experience with that as with the hips?
Well, I have had over the years have tremendous experience in both. That's primarily what I did. I didn't see broken bones or little kids with deformities. There's a lot of things that go into orthopedics, but spine and hand surgery. There are a lot of these subspecialties that people call themselves orthopedic surgeons, but they all deal with the different aspects of the problem. So my day in the office would be probably 80 to 90% degenerative arthritis or osteoarthritis patients that are, anywhere from 20 to 95.
So on the x-rays, they show no space where the cartilage is. The bone, it's bone on bone. Now, can any of those bone on bone people be asymptomatic or not have pain, or is that universal that they have pain?
Well, it's very rare to find somebody who has that kind of x-ray evidence who is without any symptoms. Now, you hit, bone against bone is very inflammatory. So it's going to cause problems for everybody. But everybody's reaction to pain might be somewhat different. I mean, classically, we would have people who come, usually older, big, burly guys would come in who had, very physically demanding careers or whatever, and they would come in at a later stage, and I think it probably to a large degree has to do with their pain threshold and what their physical capabilities were to enable them to mobilize and get around still, even with a bad joint like that. So somebody who's not very athletic, younger, maybe a low pain threshold we might see earlier, but they all have that common condition of bone against bone arthritis. They could have gotten it from any number of ways, but most commonly it's just osteoarthritis, which is mostly genetic.
And so those hips surgeries were invented in the 30s, and the knees not until the 60s. But I don't think that knee surgery was very successful until much more recently. I read studies as recently as 10 or 15 years ago that said that the knees, a third of them still needed painkillers after the joint replacement. I don't think that's true anymore, is it?
Well, no, if you look at the anatomy of all the joints, they're all quite a bit different. And from an engineering standpoint, it's much more difficult to achieve bioidentical performance with man-made implants in some joints than it is in others. And so, in fact, when I did my fellowship training, I worked with a guy who was a pioneer in implant fixation. How do we attach man-made materials to bones to allow people to get up and load them like normal everyday life would necessitate, and not have the implants loosen up or fail, which was probably one of that and infection because of the state of the art in terms of that. It was about the 1960s where modern joint replacement really came into its own, where we had good results that could be reproduced and held up for a reasonable length of time to allow people to return to a fairly normal lifestyle. It was pretty much hips that led the way, because hips tended to be the easiest to replace from a mechanical and engineering standpoint, and from a fixation standpoint. So I'll say a little bit more if you'd like, but
Yeah, go ahead.
a lot of technology that goes into that. And like I said, when I did my fellowship, I was with a guy who was considered, he's internationally known for his work, but it was somewhat of a rogue orthopedic entity, because he was pretty much a lone wolf. He did most of his work on his own. He didn't collaborate with others in the medical profession. He did at that time, this would have been late 70s, early 80s, work with industry, which was fledgling at that time. The industry was just beginning because of the new success of joint replacement being more widespread. Like I said, it started in the 60s, but it really became more accessible to patients and to doctors throughout the world over the next 10 to 15 years. And so that meant there was a huge influx in money, of course, industry, and then you follow with government. And I'll say more about that later down the road if you'd
Sure.
like. But basically, that's how it all began. And it began with advances in technology and fixation, the strength of materials, the bearing surface designs. And there's just, it seems like a very simple thing to put in like a new metal shield on the ends of the bones, but it's way, way more complex than that. Most people aren't really aware of that.
You ended up with a patent together with your mentor for an orthopedic device. Tell that story briefly.
Well, it's actually, it was somewhat peripheral to orthopedics, in that what I did during my fellowship with this gentleman was, at the time, he was doing a lot of knee replacements. In fact, I'll back up just a little bit. I said he was pretty much internationally renowned, but what really attracted me to him, I think, was his ability to do things independently. And he actually developed knee replacement instrumentation, the tools that we use to install a knee implant. He made those, designed them, and made them in his garage. This, of course, was in the 1970s. This would have been at a time where we didn't have the tremendous scrutiny and restrictions and so forth on how everything gets to the market. But they were really ingenious, and it allowed him to work in the field which he chose, this implant fixation technology field, where he could use his instruments to attach implants to bone. Well, that, of course, led to different design in the implants themselves. And there was a lot of work being done on the implants in terms of the materials that were used, biocompatibility, their ability to hold up, not break, not wear down, for example, like car tires. So there's just a huge science to all that kind of stuff. And he was really at the forefront. And so what my introduction to him occurred at a time, and the only interesting part about this is that joint replacement was a big bloody operation, especially knees and hips. Big operation, a lot of bone dissection, tissue dissection. And I got into this, as you recall, right at the point where, the HIV problem became apparent, became known. And if you remember back in the early 1980s, when we first learned that the blood supply, the blood banks were not as trustworthy, or not as, not trustworthy is not the term, but not as reliable from a patient safety standpoint, particularly with regard to HIV, that we had to be careful about doing these big surgeries and then exposing patients to the risk of donor blood. Okay, so donor blood, there was a period of time, about a year and a half, where we didn't have the ability to assure patients that donor blood was safe.
Sort of like COVID today.
Yeah, we may be.
Anyway, sorry.
Yeah. No, that's true. So what we did is, I recognized from my training, which I had just my residency in orthopedics, not the fellowship, but just prior to that in Cleveland, where they were doing a lot of cardiothoracic surgery, but I recognized that they were using, and had been using for several years, a blood reclamation process where they did these open heart procedures, open chest dissections, and they sewed everything up, and they had drains which allowed them to collect the blood that was still being produced at that in the wound site, and that it doesn't immediately stop completely in patients who have had these operations. Well, the same was true in orthopedics, particularly when we had big surfaces of the bone that were cut that you couldn't really cauterize. So their bone is a very highly vascular tissue. So there were patients who were losing a lot of blood. And so we had to then decide how we're going to manage this. One option was to have them donate a blood ahead of time, autologous pre-donation, which you probably remember. And that's just a big ordeal. It's expensive. It had its own set of problems and misfires. But we decided that if the cardiothoracic surgeons could do it, we could do it. So we set up a system where we could reclaim the blood from an orthopedic wound. And there were many cases, Bob, where we had done these big revision procedures, which were particularly bloody operations. And we were having 4 and 6 unit blood transfusions over, the first 24 hours. Well, that's totally unacceptable. So we decided that, well, like I said, it's still the patient's blood. We're going to send that blood that we collect in our drain systems through a process that separated the blood from the bone marrow in what's called it's a micro filter that is usually used when you connect anybody's blood, donor blood, to the patient. We did that, but we also had a process that was proprietary that we developed for separating the fat in the blood, which is, as you know, significant when you're talking about bleeding from bone. So everybody had been hesitant up to that point, but it was basically a process that allowed a fairly simplistic, not necessarily high tech, but fairly simplistic and realistic, rapid turnover of the blood that came from the wound and reinfused into patients. That was pretty dramatic. So for a few years, that became a standard.
Yeah. Before you go into that, I want to tell the listeners that the way you dove into this was your mentor. You had a patient that lost a tremendous amount of blood and maybe would have died. And so they said, Jeff, you're staying up all night. You're going to hang out with this guy and you're going to filter all the blood that comes out of there. And so it freaking worked. and the
Well,
patient recovered instantly, had no problems at all. And so after that, they had something that they could patent or something like that. Isn't that the story?
yeah. So basically, and I was, I don't know how your audience understands these kind of things, but I think this all gets back to autonomous decision making by doctors, and that's really been made much more difficult now. But basically, yeah, I was up at night. This patient had lost 4 units of blood. We ran out of blood in the blood bank that was eligible for him to be
In other
transfused.
words, they didn't have the right type.
Compatible blood, yeah.
Yeah.
So I said, okay, we had talked about this. I called my mentor at the time, the surgeon, and we discussed it over the phone. He said, "Yep, just do it." So we did it, and the patient was remarkably healthy and pink and energetic the next morning. And of course, this is a desperation thing. It's very fortunate that it worked out as it did. But it led to further study and repetition of this kind of thing. And we developed enough of a database that we were able to attract the industry people in, and that's where it went from there. And so, yeah, we had a fairly good thing going there for a while, but yet things change and technology changes. So that was a blip in the management of patients who had joint replacement that lasted for a few years in terms of how you treat that particular problem.
It's crazy.
We were very fortunate.
So, Jeff, do you have any experience with all these other, elbows and all that other stuff? I mean,
Yeah, I've done a few. Elbows are pretty rare, Bob, as are most other joints. The up and coming joint right now in terms of frequency of the procedure is probably the ankle. But again, it really gets back to the technology that's available to adapt to that particular joint, and they're all different. So hips and knees tend to be the easiest. But you mentioned earlier that hips do better than knees. Knees still are very hard to reproduce the natural performance, and we haven't gotten to that point. A lot of people would argue we're not there with hips, but we're pretty darn close. But knees are a very mechanically much more complicated joint than most. Elbows are like that. The thing about elbows is they're not subjected to the same types of loading conditions. So, even they're smaller bones. We have to use smaller parts, and again, depending on how it's loaded, how often, there's a tremendous influence there in terms of what we're able to do and not able to do. But yeah, fortunately, not too many people have to have their elbows. Shoulders are getting to be very good now, and I think you're very fortunate to have your shoulders done at a time where we can say this.
Those hips got some sort of award for the best surgery in the 20th century, didn't they?
Yeah, I think it'd be like the Apple computer or something. I think back probably as I said, in the 1960s, when they really hit their stride, and so to speak, and they were widely accepted and done around the world. And now hips are very reliable. There's still their share of problems that can occur. Most of that's post dependent, meaning the patient's preoperative status plays a big role in all this. It's not all just the technology or who installs it.
So, Jeff, I've got all kinds of questions, random stuff, and interests, but I want you to first take this in whatever direction you think is best, if you want, and then if you'd rather have me ask questions, I can do that. But is there what sort of things do we want to cover before we run out of time?
Well, I'd say really quickly the role of joint replacement now, returning people to preoperative performance, is good enough that you shouldn't ever fear it in terms of the outcome. I think.
Okay, sorry, Jeff. I had to get the dog shut up, and he's having a fight with the gardeners.
Not a problem.
Yeah. So go ahead and explore some things that we should not miss.
Well, as I said, I think if you're having trouble with your joints, and I'm talking about the major joints, you see your doctor. Your doctor determines if you're a candidate, and they have very selective requirements that that make for good results. But good results are possible, so you don't fear it. But you know, going into it, it's going to be a bit of an ordeal. The surgery itself will probably take anywhere from an hour to 2 hours for most joints. It normally does not require blood transfusion now for a lot of reasons. It's not done, minimally invasive, even though they'll use that terms. It's not done percutaneously. So you're going to have an incision, and you're going to go through the usual post-op recovery and rehab. That's going to take you probably 2 weeks to get away from the pain medicine, to get up on your feet and do a lot of normal daily activities, but nothing rigorous. And then for about the first 3 months, you're, in most cases, if you're in pretty good shape going into it, you're going to rebound to a point where you can recover most of the normal things that people do. Let's just say older adults who have the common forms of arthritis and have the surgery, you're going to probably do that within 3 months. But if you're talking about peak performance for most of these joints, elbow, shoulder, knee, hip, you're looking at probably a year before you're going to get that peak athleticism back. And it takes quite a while for the joint scar tissue to remodel, and it takes an equal amount of time for most people to regain lost athleticism in terms of muscle and flexibility and balance and all that kind of thing that goes into athletic activity. So that's kind of it in a nutshell. There are complications. The risks are pretty minimal, usually about 1% for infection. And a lot of that depends, again, on your pre-op status. It's good enough results now that you don't fear that possibility unless you're very high risk, in other words. So mechanical failure, again, you're probably going to go 10 to 20 years in all likelihood, even under a normal lifestyle loading condition. And there are many implants that are out there 25, 30 years old, so you can't discount that possibility as well.
Jeff, I'm not so concerned about peak athletic performance. We're not the men we once were, are we?
Well, Bob, you were always quite an athlete. So.
Well, I'll take any praise you heap on me. I've heard that joint infection is a life-altering experience. So you really had 1% of your hips get infected. That must have been horrible.
That's kind of a national figure, Bob. We were probably a little bit below that, maybe 0.6%, something like that. And again, I mean, there's a whole team effort that goes into this, but the number one factor is, again, comorbidities, things that are you carry with you as baggage when you go into it. And the doctors nowadays are generally very good at explaining this and identifying that kind of a situation. So
you send them all to the dentist, don't you?
If they haven't been for a checkup recently, within the past 3 to 6 months, we used to do that. Yeah.
There's a thing called a spiral CT scan that you can identify these hidden apical abscesses. So if I was an ortho, I think I'd send everybody for that, and the dentist, and get a urinalysis and everything else. Send them off to see the wizard.
Wow, we had pre-op laboratory battery of things that we did, and I say did because I haven't done this in the last year and a half. But it's a very, very comprehensive approach.
So what do you do for these ones that get infected? You have to take the implant out and you put them in bed for a month and a half while they.
It's pretty rare. That figure that I gave you is sort of encompasses just about all comers. So if you have people who are immune compromised or whatever, or very sickly older people, people on steroids, for example. I mean, there are just a number of things that might render you more susceptible. But for the people who are just average guy who's pretty healthy, maybe 60, 65 years old, it's quite rare. And most of those patients are treatable. It almost always is going to involve another surgery or 2 surgeries. Generally speaking, when you get an infected joint, you have a foreign body that has to come out. You know this as a surgeon yourself. And then you have to have a period of time where people are treated for the infection with the appropriate antibiotics. And then you have to have a wound that is ready to be reimplanted. In other words, a second operation would be the second part of the two operations that might be used for treating an infection. So you're on your third operation here. Now, not all of them have to be removed. There are some very selected cases that you might not have to remove the implant, but almost, most of them, I'd say probably 80 to 90% requires a 2-operation procedure to treat the infection. But again, the results are pretty good on those situations.
So you leave them without an implant for a while.
Well, we put in, depending on the joint, for hips and knees, we have to put in at least what we call an articulating spacer. So we maintain the tissue around it. Otherwise, things get very contracted and shortened up, and it's very hard to ever restore a normal joint again by reimplanting the anatomically correct implant. So yeah, we do that. It does allow people to have a somewhat restricted lifestyle, but still a potential ability to take care of themselves. And this is, for most people, it's going to involve at least a 3 to 6 month commitment to getting better. So, and 2 operations for the majority, like I said, after you have been discovered as a patient with an infected implant. So it's it's something that no doctor or patient ever wants to see, but that's the reality. We still deal with it.
So you mentioned earlier to me before we got started that a large percentage of your campers were revisions. Is that true? And what percent?
Well, when I say revisions, I see patients who are all comers. I see people who come in with problems from their 20-year-old joint replacement that, I didn't do. And I see patients who come in with an infection from the guy down the street, it wasn't necessarily all my problems. So, I mean, that's just the reality of this kind of a practice. And that's true for all the orthopedists who do this sort of thing. So we do generate our own share of problems, and I certainly did that. But, in order to justify continuing to do what you do and good moral conscience, you have to have at least some ability to help enough people to make that worthwhile.
That sounds like a tough practice. I couldn't stand dealing with complications. It was just the most tough part of my thing. Yeah.
What I admire about you, and I saw this to some degree myself, is that you're dealing, as a cosmetic surgeon, you're dealing with trying to match a patient's subjective desire with your work, where as a surgeon, you can't always do what you want to do. It's always a situation of trying to inform your patients ahead of time. But with orthopedics, there is that attitude too, that people come in and says, well, this is the most successful operation there is, and we should all have perfect results. And of course, we all know that's not achievable.
Wow. How go ahead.
Yeah, no, it's a stress. You live with it daily. It's a very high pressure kind of thing.
Hasn't your stress reduced greatly since you got out of the whole game?
I always tell people I can't recommend it enough.
Yeah, I feel the same way.
That was a good part of my decision. You and I both know that COVID changed things dramatically. The introduction to the EMR made things difficult for us old timers.
So the EMR is electronic medical records, and the numbers of the amount of time that the average physician spends on that is at least a third of their time. So they took these relatively busy professionals, very busy professionals, and they gave them a 30% more work to do, because in order to get paid, you have to go home and click on your click in the boxes. And I think your wife spends a lot of time with that now because she's still in practice, isn't she?
She does, and she's a dermatologist in an academic setting. She comes home after 8 hours in the clinic, and then has dinner, and then has to go to work for the next hour to 2 hours doing her office, her clinical documentation. It all has to be done on complicated electronic medical record programs, and it's sad. I mean, you and I grew up in an era when we were able to do this on the fly with the patient in the room a lot of times, or maybe within a minute or two after we left the room before seeing another patient. It's just gotten so over the top absurd that a lot of doctors became so disenchanted, particularly the older guys, the guys that didn't grow up with a keyboard in their hands. They found it too burdensome, as I did.
As a cosmetic surgeon, I never was subjected to this, and I had paper charts to the end. and that was a wonderful thing. And I've just gotten rid of them all.
Yeah, no, well, that's a good to
I
start.
had a garage full of them, or I've gotten rid of most of them. There's a few
Yeah,
that are within 7 years.
I'm 7 years since my private practice, and everything since then was in my academic practice where they assumed all the records. So that was a big help.
So before we hit on whatever else you think is important, I just want to make sure we hit this idea.
Sure.
Steroid injections make things worse. Isn't that correct? I mean, you get relief for a month, but they ultimately destroy the joints and the cartilage.
I think my own approach with steroids is that if it was absolutely critical for somebody for some reason, and you can go through all sorts of scenarios, where somebody is in dire pain and cannot have surgery, but is scheduled for surgery or would be scheduled for surgery otherwise, it might buy them a few months and you only get one or two. The problem with steroids is that it is a risk for infection after you've had a steroid injection. It's a risk for infection leading to a surgery. If you're headed for surgery and you know that, within a short period of time, but it's also somewhat destructive to the joint. I mean, you're essentially rendering a joint pain-free, feedback-free, other than maybe some noticeable stiffness, where patients then would go out and otherwise protect it. They're out there loading it heavily. So you see a fairly rapid destruction, not to mention the systemic effects of steroids. The injectable steroids didn't have such a great amount of systemic problems, but it's just a reality of what's there. So I think you're always better off if you can maybe avoid that.
So you're an Eskimo that knows too many names for snow, Jeff. All you had to do was say, yeah, avoid the steroid injections to make me happy. So okay. I remember I'm an emergency physician. Yeah. They either go upstairs or they go out the door. So related question, and forgive me for my cynicism, but I've overheard orthopedic surgeons talking about this, and they say that once they have a knee patient, they have them for life. And what they do is they initially start out with steroid injections, which aid in the rapid destruction of the joint, unfortunately, give them some relief though. And then they go on to endoscopic cartilage removal, which completes the destruction. And then they have to do the surgery. Now, you're not so, I'm sure you were not so calculating, but I think some of them are. And you could address the idea of the meniscal or the cartilage removal, the nipping and tucking of the cartilage, and how that has been disproven by randomized surgical control trial.
I think you're absolutely right. I think that's way overplayed. And what we know, I saw regularly in my practice were people who would come in and say, I never had any knee problem before, and I know I'm 60 years old, but I was out raking leaves, or I went out and played a little softball with my kids or whatever. And boy, I came up with this. I twisted my knee. I came up with this problem. And I thought, okay, well, how many times did you do that prior to this in your lifetime? And you never had a problem. So first thing is you have an elderly degenerative meniscus and it tore, and that's what happened. But it was going to tear at some point, and it was probably going to be very soon no matter what you did. So those patients have, by definition, degenerative arthritis in their joint from that point, because we know from that point that's sort of the introduction to the problem. It's probably been there for a while. It's an aging process, but that's what happens. So those people are, a year away, almost always, maybe a little bit longer in some cases, and certainly a little bit less time in other cases, where they're going to have bone against bone in addition to that torn cartilage. So I would try to tell people this, but you'd be surprised the resistance that people had who are usually, very athletic and sort of youthful people, to hearing that you're getting old, that your joint is beginning to wear out, and you're going to need a knee replacement before long. Little by little, they would come around, Bob, because they would continue to have the problem, whether somebody injected them, whether they had arthroscopic surgery, or whether they tried to go to physical therapy or whatever it had, you name it. None of that stuff is anything more than a very quick short-term fix.
Stem cells completely correct the problem, though. Is that correct?
Sure it does. Yeah, that and a good shaman will really help you.
Okay, so tell the audience a little bit about your approach to overweight people and the thresholds for not even considering hips or knees and so on and so forth about that.
Well, we use BMI, we use a number of factors, but joints actually can hold up quite well if you can physically, technically do the surgery on an obese patient. The problem that we saw was the technical ability to do it and to have the wound heal without a complication. That's what obesity means. It isn't necessarily, well, if you do this on a joint, a fat patient, he's going to wear it out or he's going to break it. No, that's not usually the case. Those patients tend to be actually less active and load their joints less than most patients do. So my patients where I was able to successfully do their joints, their knees, their hips, they did fine. Trouble is, it's a very high risk for the surgery in the perioperative period.
So now I'm sorry about all this geeky detail. It's not geeky detail for you, but it is possibly for my listeners. But tell us, does everybody take blood clot thinners or blood thinners,
Yes,
the oral agents, and for how long?
that's standard. And most people, we did it, and I think the standard still is people would take it for at least 3 months. But there are different opinions on let's just say the standard approach to a healthy patient. But there's so many different, again, these comorbidities, things that people come in with that may dictate that you have to alter your clotting approach. So yeah, we used aspirin on a lot of basically healthy patients, but we'd use a small dose for 3 months, and that's not a real high risk for people who are active. So the goal was always to get people mobilized as quickly as possible, limit that downtime. That was one of the biggest factors.
So my last question is, tell us briefly about this metal problem that all those hips had and how they all had to be removed, or most of them had to be removed. And I mean, I read a story about an orthopedist who had it happen to himself, and they said they got into his hip and it was all black from the metal rubbing off. It doesn't sound good to me. And then of course, he recovered once they put the modern implant in. This is not a recent problem, but this is something Jeff still faced. He was removing and replacing these things towards the end of his career, even, weren't you?
Well, I put a few in too, Bob. So, you're talking about a technology that went through an evolutionary process. You said, this guy had this older implant replaced with a modern implant. Well, at that time, you go back and there's iterative examples of different technologies that at the time were thought to be state of the art. So you can't just always impugn, somebody's implant versus another implant. There were some differences in some cases where there were clearly defects or flaws, but metal on metal hip replacements became common about, I'd say 2005 to 2011, 2012, when we started to see wear debris that formed at that articulation. But the reason that metal on metal came about was because the traditional metal on plastic components were having problems already. That was an attempt to solve that problem, but it turned out to produce its own set of issues. So we all went through revisions for failed metal on plastic hips and other joints as well, because that was a standard for most joints, and still is. But the difference now is that we have much better polymers that we can use for the plastic component. We have better, less friction producing metals and ceramics to create that interface that we now have that's much more durable. So yeah, there were issues where the particulates that formed both from plastic on metal interfaces and metal on metal interfaces caused local tissue destruction. And sometimes it was catastrophic. Sometimes people didn't really know that they had much going on until they came in with a little stiffness and had an x-ray done that showed destruction of bone and even loosening of the implants around the bone because of it. You get in there, if there was metal on metal wear, a lot of times we call that metallosis. You'd see tissue that was stained black from that metal debris. And the bigger problem is the actual destruction of capsular tissue and tendons and the bones surrounding it, which could make very, very challenging reconstructions. But yeah, we do have much better and much more durable implants now, where we're not seeing that same kind of problem within just a few years. We're now looking at, I think, most patients going, like I said, probably 20 years, 10 to 20 years with minimal complications, if any.
Jeff, I think that you had one more topic you wanted to discuss, at least that had to do with how medicine was going and so on. But before you wrap up, I want to say what a pleasure it is to talk to you every single time, because it brings back the same feelings I had when we were driving those little go-karts in and out of our driveway when we were 12 years old. You were probably 8 or 9,
Oh yeah,
and I was 12. And
yeah.
you know, I hung out more with your older bro.
Yeah, no, you were the older crowd.
Yeah.
Well, no, it was, yeah, we had a lot of fun, Bob. It was really an exciting time, and we learned a lot about life, that's for sure.
I don't know about that.
But I just want to say that I admire so much what you're doing, because you're pointing out some of the problems that we're seeing in healthcare. And Lord knows we have a lot of problems with cost and with accessibility and all that. And I think, your audience probably is more astute than most in terms of understanding the reason for this. But, I practiced for almost 35 years, and I was in a solo private practice, I was in a group private practice, and I was in an academic practice. Except for government or military, I've had, a full exposure to what's out there from a doctor's standpoint. And you and I, we saw what happened with this creeping socialization. We saw what happened when government started funding healthcare, right? We also, as what we've been talking about, we've also seen how the successes in the technology in healthcare started to make healthcare and the delivery of healthcare a very lucrative type of thing, not only for physicians, but for industry in particular. And so you had this more heavy-handed approach, growth of the government bureaucracy and third-party payers that came in, and they wanted a piece of the action, essentially. I mean, first of all, I think it's unconstitutional to even have government funding healthcare to begin with. And my liberal colleagues will say, oh, but we have to have this, and this is such a great thing. And I tell people, look, we don't have that ability to solve everybody's problem. And to pretend that we do is crazy. It's going to cost a fortune. We just physically can't do it. But we also understand that doctors have to remain autonomous. What we've seen, and I've seen this from all different viewpoints in those practices that I've held, is that we've seen the third-party payers and the government third-party influencers from all sides have such a control over what we do that we don't have the ability to individually treat patients anymore. We have lost physician autonomy. You and I both know that even during surgery, we have to do things that aren't exactly, we'll say, consensus treatments. Certainly, we use off-label drugs all the time, right? We're doing all these things that we have to do because we have no alternatives, and we're trying to help patients. Well, we now have a situation where, just as an example, you can't do those things because it's not on the drop-down menu of allowable treatments or procedures, and you have to face the consequences if you decide to do that. Most doctors have done two things. They've escaped by consolidating themselves with a huge group where they don't have to worry about all the aspects of practice management and the worries that you're not complying with the latest this or that, or you're not with the program as far as the latest EMR requirements. So you have fewer independent doctors, and you have less ability with each doctor to make those independent decisions. And I think that's a very sad situation. That's a perspective that I've gained and understood probably better in this past 2 years with COVID, where you see that, people, we don't have all the answers. We don't have, as doctors, we know that the human body is impossibly complex. Our ability to understand the disease, human disease, is so limited that it's just too bad that we've had now our hands tied. We can't really make decisions without facing, the usual penalties or traps. Used to be we just worry about the civil litigation, medical malpractice type of thing. But now it's every aspect of what we do is so scrutinized and so controlled that you wouldn't venture out of your little safety zone at all if you're smart. And that's too bad, because it really restricts innovation and it makes treatment inaccessible or impossible for patients. So anyway, that's my screed for the day. But I can tell you, a lot of people don't understand this. And it's just sad.
Well, it's apocalyptic. Jeff,
It's,
we'll get together soon and chat more off the air. But I'm grateful for your things that you help my listeners understand. And we've got a group that some of whom are considering joint replacements, and they have arthritis, and they have to understand what's up with this. And I didn't come easily to the idea that I needed my shoulders replaced, but when I understood that I had a good surgeon available to me and that the results were likely to be excellent, I went for both of them at once, within a short period of time. And of course, they don't do both of them together because of hygienic problems. That's the last joke for the podcast.
Great. Well, thank you, Bob, and I appreciate the offer to come in and share my experience with you.
Okay. Thanks, Jeff.
Take care. Okay.